Hello, this is Dr. John Kruse, and today I'm going to be talking about what we know right now about a year into the COVID pandemic and COVID and mental health. This is not particularly directed at ADHD aspects, but more general psychiatric issues in COVID. I'll be talking for 20 minutes or so, and if you have questions, certainly you can type them in as I'm writing, and I'll get to them at the end. And you can also find this on Facebook or YouTube later, and if you have comments then I can try to answer them. And the preliminary answer is that everything we know right now is preliminary, so we don't have clear-cut big answers on some of the questions. So there's two different angles on the mental health COVID issue. One is whether people with existing mental health issues are more at risk for infection or for more at risk for serious infection, or the most serious outcome being death. And the available evidence there is that it seems to depend on where you're looking. So countries, in Korea, mental health indices didn't seem to be strong predictors for these. In the US and some other countries, they actually seem to be more informative. And part of what's hard to tease out is that, at least in this country, the poor, people with socioeconomic factors are strongly correlated with poorer mental health or greater mental health diagnoses. Poorer physical health is clearly correlated overall with poorer mental health, and we know that there's a host of physical health conditions that predispose either to serious infection or death with COVID. And there's also growing awareness and evidence that a range of mental health issues, particularly depression, maybe schizophrenia, maybe ADHD, and some others as well, are associated at least with heightened rates of immune dysregulation and immune system problems in the central nervous system. And immune system dysregulation may again put people at more serious risk of mental health. So at least in the US, the data does suggest that people with pre-existing mental health conditions are more likely to develop contract COVID, to have more serious cases, and if they have it, to result in death. The other thing I'll address in this angle of it is that overall, having a mental health condition, people with mental health pre-existing conditions do perceive increased stress, increased burdens in terms of increased depressive anxiety symptomatology, but interestingly, their increase in stress and increase in worsening mental health is less than the increased worsening of mental health in people who didn't have pre-existing conditions. So COVID's bad for everyone, but it's actually been a little worse for people who didn't already have conditions. And how much of that is because people who are doing poorly already were doing poorly, or how much of it is because some aspects like depression, loneliness, anxiety, people who already had those conditions feel normalized by the pandemic, may be part of it. So enough of that angle. More of what I'm going to be talking about is what has been the impact of the pandemic on mental health rather than the pre-existing effect of mental health on COVID. So there's several reasons people have been focusing on this from the very beginning, even before we knew whether there would certainly be an impact, and that was there are several different routes of potential causes for problems with the COVID pandemic and mental health. One is, this is a virus which we've known since fairly early on can have direct impact on the central nervous system. And one of the most classic and diagnostic symptoms of COVID, not that everyone has it, but that few people have this symptom, particularly of a sudden onset, is loss of smell. So again, not everyone with COVID has it, but it's clear enough and diagnostic enough that it seems to be a useful marker for COVID, but it tells us, particularly if you're using the central nervous system, not just to mean the neurons involved, but the supportive glial and other connective tissue and other cells, part of the nervous system. Clearly, this is a virus that affects the central nervous system. Again, with the anosmia, lack of smell, it may well be that it's affecting glial cells and immune cells that are in the brain or in the central nervous system more than it directly affects infects the nerves, but it's having a direct impact on the central nervous system. And if it's affecting smell, it's not that strange. It may affect other parts of the central nervous system, at least in some individuals. So reason two, and this is closely allied to direct viral infection, is that there clearly in many people is a robust and a dysregulated immune response in the body, and that includes in the brain. And there's been a lot of attention on long haul COVID, or some people just call it long COVID, people who seem to have recovered from the acute infection but have a host of symptoms, most of which are in the psychiatric, neuropsychiatric realm in terms of fatigue, mental fog, sometimes continued lack of smell. So again, that may be a reason to be looking for other mental health issues. This is also a virus. It's not just a biological factor. It's clearly having a huge social impact, and particularly social isolation and loneliness we know has gone up markedly during the pandemic, and we know that in general social isolation and loneliness is as big a risk factor for other health and mental health problems as some of the known health problems like cigarette smoking or diabetes. So loneliness itself is a important factor. The flip side of loneliness is, while we're sheltering in place, many people are having enforced togetherness, so they have less escape from people than they might usually, and particularly in the realm of domestic violence. It was hypothesized that would be a clear trigger for worsening of prevalence of domestic violence. And then sort of at the fifth, even bigger or more meta or more distant effect of the virus is that it's clearly had a huge economic impact on our society, and the financial, economic, how our whole society is organized, how work is organized, and including differential effects on particularly communities of color and people of lower socioeconomic status. This has had a big impact. So the predictions and mental health papers about COVID are actually the biggest field within COVID research and publications right now, and for a few months has been the mental health area because of these myriad of causes. The majority of the papers so far have been more speculative and raising concern and raising worries and concern, but the concerns were we would see increases in depression, increases in anxiety, increases in PTSD, increases in suicide, increases in domestic violence, and increases in substance abuse. Now, one of the great difficulties of measuring things or getting hard data in a pandemic is that if you do, depending on how you do your study, if you see a change in the rate of one of these problems, or if you don't see a change in the rate, is this change really reflective of how common the problem is in the community, or is it just a change in the reporting? And the most notable thing is that we know ER visits have gone down markedly in the United States and all other countries as a result of COVID precautions, and particularly for people presenting with panic attacks, people with suicide, the vast majority of those enter the medical system through the emergency room. So if you're seeing a decreased rate, it may just be that you have fewer people reporting or poor ways of surveying what's going on, not that there's a real decrease in rate. Connected to that, separate from just ER and surveillance in clinics, and we know even just general clinic attendance has dropped markedly. Skewing things the other direction is that if you're doing surveys online or recruiting people, you're going to preferentially get people who are more either stressed out or worried about COVID, or worried or have suffered greater physical or psychological mental health implications from it. So it's hard to get a clear, the question is, what are you comparing to what, and how representative of is your sample of the general population out there? And then particularly, and maybe more so in the US than in most other countries that are having a lot of active research on health and mental health implications, one of the big problems in the US, and this is directly related to President Trump, ex-President Trump, suppressing our ability to test for this virus accurately. He repeatedly, and this is not just my political view, he himself said it more than once, he wanted to keep testing rates down. He thought we were doing adequate jobs. But the current, so I'll highlight it with numbers. Right now, most people are aware. 500,000 Americans have been dead due to COVID. If anything, that number is a slight, or at least a undercounting, because we know people have had COVID. In New York State recently, people in nursing homes, if they died in the hospital rather than the nursing home, it wasn't even attributed to the COVID death rate. So we also have known 28 million cases of COVID. Now, if you do the math, that results in a 1.8% fatality rate, which would suggest if everyone gets infected, we might be seeing close to 5.9, almost 6 million deaths in America. However, we can be pretty darn certain that 28 million cases is widely underestimating the actual number. But then again, it's skewing all our statistics and calculating things. Now, in the other range, many, particularly on the right, who pretended they were being objective, were saying this disease only has a 0.2% fatality rate. Now, if they were accurate, then with 500,000 deaths, their claim would mean that we've actually infected 250 million people in this country, that the rate of actual cases is almost 10 times higher than the known detected cases. And it would also suggest we're actually pretty close to herd immunity, even if we don't do further infection, because more than 3/4 of the population has either gotten it. Clearly that number is wrong. Clearly their claim that this disease only has a 0.2% fatality rate is just flat out wrong and underestimating grossly. But again, it's highlighting we don't even know how much COVID is out there. We don't know how much asymptomatic infection. We don't know how much mild infection that didn't get to become a statistic in our medical records because we're doing a lousy job still of testing. So another conflating factor figuring out the difficulty in sorting out what's really going on is that the bad outcomes, fortunately, are low. So again, whether it's 0.2%, clearly that's too low. Whether it's 2%, that's probably higher than the fatality rate is. Fatality is a low event. It means that at least 98% of people who get this virus aren't going to be dying from it. But again, that makes looking for bad events difficult because, for example, if you were a doctor several months ago, using hydroxychloroquine and you had, gave it to your first 50 patients and they all survived, you'd be thinking, great, I have some wonderful treatment for it, without realizing, if 50 people who walked in the door probably wouldn't have died even if you had given nothing or spit in their face. I'm being flippant there on purpose to, again, subsequent studies have very clearly, robustly failed to find any benefit from hydroxychloroquine or chloroquine. But again, we needed more rigorous studies and we needed to have relevant comparison groups. So my summary, and in the few hours, the last few days, I went through more than 20 different studies that were out there. One of the most reassuring things, and again, this is preliminary, this is not final. So what is the gist of what I've summarized out? One is that there were marked increases in perceived stress early on in the pandemic. Self-reports of depressive symptoms, self-reports of anxiety have certainly increased. Those seem to have increased most abruptly during the first shutdown and shelter-in-place stages. Rates have decreased since then, so it seems that at least part of the initial surprise shaking up our world, people could adjust to. Again, most of these studies weren't looking at rigorous full depressive symptoms or anxiety symptoms. And my other summary, and again, this is certainly completely preliminary, but there have been a number of studies from a number of parts of the world, including Vermont, the whole US population, Korea, Australia. The one bright statement so far, and if you look in narrower areas, because there have certainly been county-level studies which suggest increases in suicide, but the suicide rate actually seems to have dipped slightly in the first few months of the epidemic, and overall for the year, in most larger areas that have been looked at, has not increased overall for the general population, has not increased overall for the youth population who've been thought to be most at risk. There may be, and there are some, again, need further corroboration and better controlled studies. There may be in populations of people of color and lower socioeconomic status, there may be an increase in suicide rates there, but that's not definitive yet. So why may we, so that sort of raises a question. And with suicide, unlike ER visits for measuring, domestic violence, so I'll get to that. So the domestic violence data is more all over the place. Some suggested decreased rates, some suggested increased rates. Clearly, the reporting has a huge factor in domestic violence rates, because if you are being abused by someone you are sheltering in place with, you may have much less access to notify any authorities or for to be recorded. Most deaths in most of the areas where we're doing epidemiologic research are getting registered, and if it's a suicide, that will show up in the statistics. So again, it does not seem to be simply a reporting bias that is failing to find an increase in suicide so far. So one question is actually, could sheltering in place in this whole epidemic be suicide protective? And I think, again, it could be in two ways. One is there has been, since the beginning, a huge awareness that there could be a pandemic of depression, anxiety, and suicide. So all the talk about it and taking protective measures, and at least when I listen to the radio or look online, there is a wealth of people reaching out, telling people to take good care of mental health, offering tips on, dealing with Zooming 400 hours a day, or decreasing stress or de-escalating conflict when you're living with people. So potentially, and it will take a while if this is true to sort it out, maybe our greater awareness, greater discretion, and raising the flag early has averted some suicidality and some of the most severe, horrible outcomes of depression or anxiety. I think another factor, particularly with youth, is that sheltering in place probably has directly saved lives, and by that I mean many suicides have at least some element of impulsivity and some element of doing it in private. So if your parents are away, it's easier to hang, shoot, poison yourself than if people are in your space. So I would say that may well have saved, kids may be more sad, depressed, anxious, worried, but adults are in forced proximity to them. There are fewer of them that are left in total isolation with probably less access to the means of many forms of suicide right now. So again, in a weird way, sheltering in place, our social restrictions may actually have had a protective effect on the suicide front. What else has come up again? And again, many of the things I'm saying are fragmentary evidence, isolated studies. It's hard to put things in a bigger perspective. But again, so far, suicide doesn't seem to be an overwhelming problem. On the other hand, again, depression does seem to be higher, anxiety does seem to be higher, substance abuse rates do seem to be higher, alcohol consumption is clearly increased. That's the easiest one for the government to measure. And PTSD, given that COVID, whether it's 0.2%, whether it's 2%, whether it's somewhere in between those, it is a potentially lethal event. And if you have COVID and it's severe enough to be in the hospital, that is a life-threatening event. Life-threatening events are one of the ingredients for PTSD. So we know certainly PTSD rates have increased. What's been interesting so far is studies with a variety of different methodologies have found rates as apparently as low. A French study, only 6% of people with COVID met criteria for PTSD several months later, and that was a population where 70% of the people with it were hospitalized. And other studies I've found have rates of PTSD as high as 30% of people who were hospitalized with COVID. So again, we don't know how high or how prevalent the risk is right now. So again, my summary is good thing suicide so far overall has not popped up as a pandemic that could worsen in weeks ahead or months ahead, particularly with loosening social lockdowns and people more free to do, more privacy to do things that they might otherwise not do when scrutinized. Clearly depression, anxiety have gone up, but it seems like on the whole many people are managing that well, and again, for some people, including with significant mental health problems before, some of this has normalized things for them. They feel more connected, more understood by the rest of the world. So that's my summary right now. I see one comment. If there are other questions might be coming in. So the talk next week is going to be reverting more to ADHD directly, and it's going to be a discussion on fish oil and whether that benefits or does not people with ADHD. So the comment is just a sort of thumbs up that I really appreciate your clear-headed and thorough analysis, and I appreciate the positive feedback, and have a good week. Take care of yourself physically and mentally, and I'll be back next Friday at 11. That's all.